I'm Philip Salem. I'm the Director Emeritus of Cancer Research at Baylor St. Luke's Medical Center in Houston, and I'm the President of Salem Oncology Center in Houston. It is a great pleasure for me to share with you the most recent results we have on Ictriplex. Ictriplex is a major contribution to the treatment of advanced cancer disease and to patients where the disease has become refractory. Next slide, please. This study was done at Salem Oncology Center here in Houston. The center is a highly personalized cancer facility, and we treat patients not only with the mind and with knowledge, but also with the heart and love and compassion. The major distinguishing feature of our center is that we treat patients with what we think is the best treatment that would give the patient the best chance for cure, rather than standard therapy. If standard therapy is considered by us as the best treatment, we will certainly use it, but we always use what we consider the best for the patient. Next. This is where Salem Oncology Center is housed. This building is located in Texas Medical Center, which is the largest medical center in the world. Next. And this is how Texas Medical Center looks at night. I chose a night with a moon there. Ictriplex is a combination of immunotherapy plus chemotherapy plus targeted treatment. We believe that the best chance to control cancer is to use all the weapons available to you. And the weapons are immunotherapy, chemotherapy, and target treatment. Next. And it is this treatment, this combination is registered under the name Ictriplex. So this is a personalized, because treatment is tailored to the individual patient, multimodality therapy with immune checkpoint inhibitors, chemotherapy, and target treatment, and the treatment of advanced and refractory cancer. Next. The reason we chose this combination is that, like 6 years ago, we already had evidence that the combination of immunotherapy plus chemotherapy is superior to chemotherapy alone. And there was a lot of data to support this hypothesis in a variety of cancer diseases. So we chose to add to immunotherapy and chemotherapy the third modality, which is targeted treatment. We were able to do that because these three modalities have convergent efficacy but divergent toxicity. Next. Every single patient who was treated in the study received the three modalities: immunotherapy, chemotherapy, and target treatment. But the treatment was tailored to the individual patient, and therefore every patient received a different treatment from the treatment the other patient received, the tumor. So Ictriplex is a treatment not only tailored to the patient, but it is also tailored to the tumor. Next. The patients we treated are patients that nobody wanted to treat. Many of our patients were told by major cancer centers in America that no additional therapy is available for them. All patients had advanced cancer, and the majority of these patients had received prior treatment and had become refractory to conventional therapy. I must say that at least 8 patients of the 34 patients I'm going to present were considered by major cancer centers in the United States as terminal and hopeless, period. The immunotherapy drugs are the checkpoint inhibitors. They are the Epi, the Pembro, the Nivo, and atezolizumab, which is Tecentriq. These are the most commonly used immunotherapy drugs in the study. These are the targeted treatments: erlotinib, bevacizumab, cetuximab, everolimus, Avastin, and a few others. Immunotherapy was given IV every 2 to 3 weeks. Chemo is given in a cycle of 28 days. Targeted treatment was usually given as a pill taken daily, but other forms of target therapy could be given IV. The criteria for response, we took the most rigorous criteria, and that the PET-CT scan, because we all know a CT scan may become negative, but the PET-CT scan may show residual disease. And in my experience, the PET-CT scan is the most sensitive imaging study for tumors. We also took the tumor markers, symptoms, and physical finding. We considered a patient in complete remission when all symptoms disappeared and there was no evidence on imaging studies and PET-CT scan of residual disease. Next. Here are the patients. We treated a total of 34 patients. The most common disease we treated was lung, 10 patients. Second is pancreas, colorectal, primary brain tumors, melanoma, cervix, cholangio, breast, ovary, stomach, thymoma, Hodgkin's, and sarcoma. And this is the power of ICT, that ICT is not a good treatment for a single disease. It's a good treatment for a variety of cancer diagnosis. Next. Response: 50% of our patients achieved a complete remission, and 38.2% achieved a partial response. So the total response rate was 88.2%. The remaining 4 patients, a patient had a minor response, 2 had stable disease, and 1 had progression of disease. Next. If we take lung cancer, and these are the most impressive results, that 6 out of 10 achieved a complete remission. One of these patients had squamous cell carcinoma, which is the most difficult kind of lung cancer to treat, with extensive metastatic remission for more than 2.5 years. And one patient with adenocarcinoma, with extensive metastasis including brain has been in complete remission for over 3 years. So 6 had complete remission, 4 had partial response. But please note that none of the patients did not respond. Next. If we take pancreatic cancer, we treated 5 patients. 2 had CR, 3 had PR. All patients responded. None of the patients had progressive disease or stable disease. And all those who achieved a PR had more than 90% reduction in disease. Next. Cervical cancer. 2 women with cervical cancer, very advanced cervical cancer, were treated, and both of them achieved a complete remission. Next. Of great interest is cholangiocarcinoma, a disease which has been looking for a good drug for a long time. We treated 2 patients, and both had extensive disease in liver and regional organs. Both patients achieved a complete remission. Next. What was also very interesting was the fact that this treatment is able to cross the blood-brain barrier and to make a major impact on CNS disease. We treated 2 patients with glioblastoma multiforme. 1 achieved a complete remission, and the other had a minor response. But all the 3 patients with lung cancer and metastatic disease to the brain achieved a complete remission in the brain. So ICT was very effective in the treatment of metastatic brain disease and may spare the patient radiation therapy. None of those patients, 3 patients, had received radiation therapy, yet all of them had a durable, complete response. Next. You may forget about all the slides I have presented, except this slide. This is the most important slide. This is where conventional therapy is. And look at the difference between ICT and conventional therapy. Complete remission in ICT is 50%. In conventional therapy, it is less than 5%. Partial remission is 38.2% in ICT, but it is less than 15% with conventional therapy. And look at the total response rate. It's 88.2% in ICT, less than 20% in conventional therapy. And therefore, ICT is a major leap in the treatment of advanced refractory cancer. Next. Toxicity, we were amazed that toxicity was very reasonable. Only very recently, 1 patient died of a severe Opdivo-related toxicity. But I believe he died as a result of a mistake because the patient developed, he was being treated out of the United States after he achieved a complete remission in our facility, and he developed Opdivo-related immune allergic reaction. But the reaction was mild. But the mistake was that the patient was given a second dose of Opdivo 2 weeks later, and before the symptoms subsided from the first episode. In my opinion, Opdivo should have been discontinued, and not to be given again 2 weeks later. For that reason, the patient developed a severe allergic reaction and he died approximately 3 days ago. In the 33 remaining patients, toxicity was reasonable and no patient refused to receive further treatment because of toxicity. The common toxicities we see in this program are fatigue, transient pneumonitis, and also transient colitis. Next. In conclusion, ICT is an extremely effective treatment for advanced refractory cancer with a complete response rate of 50% and a partial response rate of 38.2%. It's extremely important to note that this treatment is not good for only one disease, but responses occurred in diverse cancer diagnoses, and that this treatment is effective in metastatic CNS disease. I believe this is a major contribution to the treatment of cancer, and it is time to go little backward and treat patients with earlier disease with this combination. Next. My recommendation is that ICT is an excellent option for the treatment of advanced refractory cancer, and that medical oncologists who feel that the patient is beyond conventional therapy, beyond the standard therapy, they should consider seriously the option of ICT treatment. But at the same time, because the numbers we are dealing with is small, we recommend that more clinical trial should be conducted to further evaluate the precise role of ICT in the treatment of advanced cancer. My message is that if you feel you have no other option, consider ICT. I want to end this talk by thanking the Lord, as I thank Him every day for giving me the opportunity to serve the cancer patient. It has been a privilege and an honor to do so for the last 53 years. Many thanks.